Good morning, everybody. Good morning in Ukraine. Good afternoon in India. And we are excited for this excellent session. And I'd like to invite all our speakers to the Trauma Eye Surgery session according to war injuries. And this is organized by the Ukrainian Association of Ophthalmologists and Society and Salan University in Ukraine. And they've got an amazing team of speakers going to be discussing different experiences that they've had and they're having during this time of crisis and war, and how they've learned from their different approaches. So I'd like to hand it over to the moderators, Professor Oksana Witowska and Dr. Sybil Schwartz, take over. Thank you very much.
Thank you so much for introducing us. Dear Team Aronodaya, dear colleagues and friends from all over the globe, Privet Ukraina, Dobry den Kiev. Hello and good morning to all of you from Germany. At least in Germany, it's good morning. Dear Team Aronodaya, thank you so much for inviting us to your excellent conference and for agreeing to set up this session about trauma eye surgery according to war injuries. Oksana and I are utmost thankful to present this topic. It is my absolutely great pleasure to moderate this session together with Oksana Witowska. And who of you don't know Oksana yet? Oksana is an extremely versatile scientist. She's professor of ophthalmology, at Bogomolets University in Kiev, in Ukraine. She was head of the University Ophthalmologic department. She is head of the Ukrainian Alliance of Ophthalmologists. She is the scientific leader of the annual Congress series for Ukrainian ophthalmologists with international attendance, the Ophthalmic Hub. That's the name of her Congress she's running for many years now. As well, she runs an online education project. It's called her Ophthalmic Eye School. Furthermore, she is author of 242 scientific papers, 3 national ophthalmology textbooks for students of medical university, 2 textbooks for family doctors. She is editor-in-chief of National Ophthalmology Textbook for English-speaking students, and much, much more. The list will not end today. I'm incredibly happy and thankful and proud to be here with her today. So welcome, Oksana. Welcome to the screen. The screen is yours, my dear.
Dear colleagues, thank you very much for invitation and your great support. Also, it's a great honor for me to introduce Dr. Sybil Schwartz. She is an Associated Senior Research Fellow at the Institute of Experimental Ophthalmology, Saarland University Faculty of Medicine in Germany. And she's a biologist, chemist with PhD in ophthalmology, bringing a unique multidisciplinary perspective to her field. Sybil is internationally well-known and accepted as subject matter expert in biometry and IOL power calculation, and Dr. Schwartz has a strong academic foundation, is highly regarded for her international collaborations. And of course, we have great collaboration in Ukraine with Dr. Sybil Schwartz. And also, I would like to say hello to all our Ukrainian colleagues. Dear Sybil, stage is yours.
Thank you so much, Oksana, for your warm welcome. And now I would like to welcome our first speaker of the day, Frank Krugmann. He's from Tüngesheim. It's a small town close to Würzburg in Germany. Beside many other projects, Frank's list is long as Oksana's as well. Beside many other projects, Frank is an historian, and he's the managing director of the Julius Hirschberg Society, which is an international society for history of ophthalmology. For 35 years, Frank acquired a vast knowledge of history of ophthalmology. Especially he's focusing on the ophthalmology of Old Austria, Arabia, Heidelberg, and Vienna. And he acts, as you can see today, also as a speaker at national and international congresses. Today, Frank will report about the history of war ophthalmology. And so, Frank, please, the stage is yours. Welcome to the meeting.
Thank you very much for this introduction. First, I would like to thank you, of course, but especially to family Seti. I hope that was the right spelling. Well, my life has been reported enough, and I think we can start now with my lecture. Please, now the technique.
Dr. Frank, would you like to present from your end, or do you?
No, I have pre-recorded. Please take this one.
Yes, shall I play that?
Because it's 7 minutes and 2 seconds.
All right. So we have the option of slide sharing and presenting from your end as well. Would you like any of the speakers like to do that? Do let me know in advance. Otherwise, we'll download everything and play it from our end itself. Would that be okay if we download everything and play it from our end? Professor Uksana?
If you have the video, you can play it on your end and share it from your
Perfect.
as well.
We've been closely following up what's happening in the political sector, and we have all the support of the Ukrainian people, and we want to
Gentlemen,
and
best greetings from Germany, and thank you very much for invitation. Many soldiers who had an eye injury had to be enucleated. But here you see not the face of a soldier. This painting is from the year 2013 and shows sewing up of an eye cavity in a cadaver of removal of the eye for training of the
Dr. Weibab from the hall, we're not hearing the video anymore.
also in the writings of Hippocrates.
I think microphone is muted because we don't hear anything.
So I think that somebody from technical support is with us. So we cannot hear our colleagues here.
Yes, I think microphone is muted in hall B, so that's why.
Okay, so maybe we should say the next speaker, Valery Serdyuk, will be also in pre-recorded. He is trying to connect via internet, but internet is poor, so please could you hear me about next speaker is Valery Serdyuk and
under point.
Strange.
Okay, now it's okay.
Now still we can't hear him.
Okay, now we can talk. I would like to ask technical support to prepare Serdyuk Valery presentation as the next, because he is on his way and internet connection is poor. He's ready to
Are you
get
able to hear Professor Oksana and Dr. Sibel? Is the audio clear and the video clear?
No, no. Video is fine, but audio is not existing. We cannot hear the pre-recorded audio.
You can't hear the audio? Okay.
No,
1 second.
not at all.
Just 1 second. Just check once more.
On psychogenic neurosis.
Can you hear that right now?
At least we heard half of a second his voice.
I think this remembers
Now it's
to the
playing.
time and the reports 3,000 years before. Now a color photo from this book. You see here changes at the optic nerve entry caused by skull injuries. On the left-hand side, 3 photos, papilledema in brain abscess after occipital gunshot wound, caused within 2 months after the injury and surgery. On the right-hand side and above, optic neuritis in shrapnel-pierced frontal lobe, bullet hole in the orbital roof. Then partial temporal optic atrophy after base fracture. And right-hand side below, the last one, atropia nervi optici after injury to the optic nerve in the optic canal. The successes of war ophthalmology in World War II got better and better because of surgical techniques improved and the development of new instruments, materials, and of course, new techniques like corneal transplantation and new drugs like antibiotics. Now to the United Kingdom or Harold Ridley. As part of the medical service of the British Army, Ridley came into contact with Royal Air Force pilots who suffered from eye injuries, and many of these injuries included fragments of airplane canopies that were made from PMMA. Ridley noted that the material seemed to be well tolerated by the eye. In then 1949, he developed the intraocular lens, IOL. The first IOL created with PMMA was implanted in 1950. Now my time is over. I can only say now goodbye.
thank you. Thank you, dear Frank,
Very much,
for
Frank.
presentation.
Yeah, sorry about the technical glitch, but we were able to hear you very clearly. So most of the part of the presentation was very good, and I really enjoyed your presentation with the experience that you have about war injuries and the history. Thank you so much. Yes. Professor Oksana and Dr. Sibel, would you like to please take over?
And it's a great honor for me to invite the next speaker, And it's Professor Serdyuk Valery from Dnipro, Ukraine. He is head of the ophthalmological department of Dnipro State Medical University. Scientific interests of Professor are keratoplasty, glaucoma, and ocular trauma. Professor Serdyuk is the chairman of the Association of Ophthalmologists in the Dnipropetrovsk region and a member of a lot of international associations and societies. So his presentation is about our experience in combat injury surgery from 2014 to 2024. Dear Professor, please.
Yes, we are just playing Professor Valery's presentation. Would Dr. Valery be presenting the presentation themselves? Is Dr. Valery there? I think Dr. Valery, are you there?
I think Dr. Valery is not. He's on his way. So maybe we can skip to the next speaker, so we can give some time to prepare the recording.
And we have Dr. Valery present later. Is that okay, Dr. Sana?
Yeah, we can skip, but please come back to his presentation because it's very important and
sure.
afterward. So the next speaker is Dr. Vanya Konstantin, with the prominent famous vitreoretinal surgeon in Ukraine, and he's Armenian ophthalmologist practicing in Vinnytsia, Ukraine at the Podila Vision Center. And he has participated in professional development programs, including those offered by the European School for Advanced Studies in Ophthalmology. And he will present treatment of a patient with mine explosion injury and eye trauma. Please, stage is yours, Vanya.
Dear colleagues, thank you for invitation. And I would like my presentation to pre-recorded presentation to be played, if it is possible. I will show you case presentation, the patient with mine explosive injury and intraocular foreign body. Can we play it?
Just playing it. Just 1 minute, please.
Yes.
Dr. Vanik, by any chance, would you be having the presentation on your computer?
Yes, I have, but you want me to share it?
Yes, please. That would be the best, if it's possible. Apologies for this technical issue.
Okay, I must show дополнительно поделиться. Wait a minute. Do you see my screen?
Yeah.
Yes, we can see your desktop, your presentation. Perfect. Thank you very much.
Dear colleagues, my greeting to you.
Do you hear me?
I'm Dr. Vanik Konstantin from Ukraine.
Thank you.
My presentation is the treatment of a patient with mine explosive injury and eye trauma.
Please make it full screen.
Relevance of the topic. Because of military aggression of Russian Federation against Ukraine, we have thousands of killed and injured people. In cases of eye trauma, patients have primary surgical treatment of eye injuries at hospitals who provide first line of treatment, after which they are referred to specialized clinics for further treatment. Clinical case: female, 38 years old. Complaints: deterioration of vision in the right eye. At medical history, at 22nd of March 2022, she was at home, and at the time of artillery shelling, she was in the room near the window, which caused multiple shrapnel wounds to the soft tissues of the face and right eye from the glass. Next day, she had primary surgical treatment of facial wounds and right eye. 7 days later, she was referred to our clinic. Vision in the left eye 20/20 and intraocular pressure is normal. Everything is fine with left eye. And right eye vision is counting fingers. Intraocular pressure 25 millimeters of mercury. There are scleral and corneal sutures after primary surgical treatment. Swelling, traumatic cataract, and vitreous body hemorrhage, which obscures observation of the fundus. On best-scan ultrasonography, retina was attached and foreign body was located at 12 o'clock behind the lens. We performed computer tomography of orbits and there was intraocular foreign body of the right eye. This is a picture of computer tomography and you can see foreign body within dimensions of 5.5 to 5.9 millimeters is determined behind the lens of the right eye. So the diagnosis is minor explosive injury, condition after primary surgical treatment of corneoscleral injury, traumatic cataract, ocular hypertension, vitreous hemorrhage, intraocular foreign body of the right eye, presumably glass, multiple fragmentary injuries of soft tissues of the face by glass. At 6th of April 2022, we performed phacoemulsification of traumatic cataract with IOL implantation, simultaneously with 25 gauge pars plana vitrectomy with intraocular foreign body removal on the right eye. This is a short surgical video. After performing cataract surgery and implantation of IOL, I began to perform anterior vitrectomy and central vitrectomy. Then I proceeded to the removal of posterior vitreous. When I finished it, I performed indentation of the sclera to localize foreign body. And here is it. It is located at the 11:30, 12 o'clock, at the pars plana. You can see piece of glass. I inject PFCL to protect posterior pole. After which, I begin to remove this foreign body from that place. I need help of my assistant. She was indenting for me, and I, using the retractor, meticulously shaving the base near ora serrata and trying to separate this foreign body from pars plana. At trimming vitreous, we must work very carefully not to cause iatrogenic injuries of the periphery of vitreous, or of the periphery of retina or of ciliary body. Step by step, I separate this foreign body from pars plana, and I succeeded in it. I filled PFCL and lifted the foreign body into the retrolental space, performed posterior capsular access using retractor, then removed this foreign body from the vitreous cavity into the anterior chamber. You can see that we work using 3 hands with my assistant. Here we are in the anterior chamber, performing big clear corneal injection, enlarging the primary incision of phacoemulsification. You can see sutures from primary surgical treatment. And we remove this foreign body using forceps. Suturing cornea. Removing PFCL. Checking periphery of the retina. Everything is fine.
Why did they choose
I finished this surgery
assessing visual
fluid air
acuity
exchange. The
without
tamponade was air. And treatment results in 1 month. Before surgery, we had counting fingers visus and slightly elevated intraocular pressure. And after surgery, we received 2100 vision in 1 month, and intraocular pressure was stabilized when we removed swelling cataractose lens. This lady now lives in other part of our country, and I called her, and I know that in 3 months after surgery, she removed her sutures from her cornea by other ophthalmologists, and at this moment her vision is stable, 20/200. It has passed almost 3 years after surgery. This is foreign body. And conclusion, vitrectomy with removal of intraocular foreign body with simultaneous phacoemulsification of traumatic cataract and IOL implantation is the optimal method of surgical treatment for such patients. Thank you for your attention.
Thank you very much, and very nice presentation. And the next is from group of authors, Dmytro Jmurik and Igor Vasiltsov. They present Kiev. Dr. Jmurik is a doctor of medical science, associate professor of the Department of Ophthalmology and Optometry postgraduate education in Bogomolets National Medical University, and also chief medical officer of Ochi Clinic. And Igor Vasiltsov is ophthalmologist in Chernihiv Region Hospital, focused on surgical and conservative treatment of eye trauma and emergency care for visual organ injuries, and also perform refractive surgeries and trauma cataract surgery as well. So next presentation will be from Igor Vasiltsov. Please, the stage is yours. The name is Management of Surgical Treatment of Severe Combat Trauma. Thank you.
Thank you very much for this invitation. It's a great opportunity for us to share our experience in eye trauma around the world. So thank you very much, and I'll share our presentation.
Thank you very much. We're just playing a presentation from our end.
Do you see now? Yes.
You can see it? Is it visible?
I'll try to play.
Okay, you play. All right. Yes, perfect. There's no audio.
Please share with voice.
No voice coming. Just exit and reshare once more. Dr. Dimitrov? Dr. Dimitrov? Yeah. Can you hear me, Dr. Dimitrov? There's no audio and there's no voice. If you can just play it once more, just reconnect, just exit and then screen share again, stop slide share.
I'm sorry. Can you hear my presentation or no?
No, we cannot. So maybe you can just cancel it. We will share from our end. We have it.
Okay, yes. Okay, yes.
Thank you.
Webinar. It's a pleasure to
Can you hear us
welcome you all today. We are a group of authors led by Dmytro Žmurik, and my name is Igor Vasiltsov. We represent the medical center Ochi Clinic in Kyiv, Ukraine. Today we will be discussing an important and challenging topic: management of surgical treatment for severe combat trauma. Our goal is to share our experience and insights into the complexities of surgical intervention in such cases, highlighting key strategies and approaches. Since the start of the full-scale war, Ochi Clinic has never stopped working. From February 28 to March 17, we provided consultation and surgeries for military personnel and civilians affected by Russian aggression at the Vinnytsia Regional Clinical Hospital. On March 17, we resumed work in Kyiv. In total, we performed more than 1,000 surgeries. We sincerely thank to the Ukrainian Vitreoretinal Society and the large number of companies for their support and for providing essential materials despite logistical challenges. Statistically, based on data from various armed conflicts, 10-12 of all wounded soldiers suffer from ophthalmic injuries. Their figures highlight of the significant impact of eye injuries in warfare and the critical need for specialized ophthalmic care. At Ochi Clinic, we performed 298 surgeries with open globe injuries, 166 cases penetrating eye injuries, 79 cases perforating eye injuries, 53 cases ruptures. In most cases, primary microsurgical wound treatment was performed in hospitals near the front line. And in the Ochi Clinic, we performed reconstructive vitreoretinal interventions. The advancement of ophthalmic surgery focuses on minimally invasive technologies, reducing surgical trauma, including in vitreoretinal surgery. The standard today is 25-gauge vitrectomy, which allows for treating a wide range of vitreoretinal pathologies. However, challenges remain in cases of grade 3 lens dislocation, subluxation into vitreous body, and penetrating eye injuries with intraocular foreign bodies. For the removal of magnetic and non-magnetic intraocular foreign bodies, standard techniques and instruments were used, including intraocular magnets and vitreoretinal tools. If the crystal lens was clear, foreign bodies up to 7-8 mm were extracted through the pars plana. However, in cases of lens damage or when dealing with the large or irregularly sharp foreign bodies, removal was performed via the anterior approach. In this video, you can see a corneal injury near the limbus sutured for stabilization with an intraocular foreign body and traumatic cataract. The decision was made to perform phacoemulsification with a posterior capsule removal, extract the intraocular foreign body through the anterior chamber, and proceed with intraocular lens implantation. On this slide, you can see intraocular foreign bodies made of various metals, which we removed through the pars plana. A comprehensive surgical strategy has been developed for patients with post-traumatic aniridia combined with aphakia or traumatic cataract. The approach consists of two stages: vitrectomy at the first stage, implantation of iridocapsular diaphragm on the second stage. The third stage, performed within 3 to 14 days after primary microsurgical wound treatment, involved a posterior closed subtotal vitrectomy with additional procedure tailored to the complexity of each case. Silicone oil removal was performed within 1 to 2 months after vitrectomy. The second stage, carried out 6 to 12 months after silicone removal, involved the implantation of an iridocapsular diaphragm.
We used two types of iridocapsular diaphragms. In the first video, you can see an iridocapsular diaphragm with 3-point scleral fixation. This iridocapsular diaphragm consists of an artificial iris and an integrated IOL. The manufacturer supplies this diaphragm in various colors and different refractive powers. Due to relatively rigid structure, it requires implantations through a larger scleral tunnel. There are peripheral openings in this diaphragm to allow intraocular fluid circulation and prevent secondary glaucoma. However, this technique requires a large number of sutures and associated with increased surgical trauma. In the second video, you can see the implantation of 3-piece IOL and an artificial iris complex. To assemble this complex, the haptic elements of the IOL are inserted into pre-prepared openings in the artificial iris. Given the presence of an iridia, we create a special supportive structure using sutures to stabilize the complex before fixation. In the case of this complex implantation, the artificial iris and IOL are softer than in the previous video, allowing for implantation through a smaller incision. Subsequently, this complex is fixated to the sclera using the Yamane technique. This technique ensures the least invasiveness and the most atraumatic fixation. The suture structure is removed after fixation.
Minimally invasive technique was developed for suturing the capsular bag and implanting an IOL in case of complete lens dislocation into the vitreous body, which involves the use of perfluorocarbon compounds to elevate the lens and special fixation elements to suture the capsular bag. After posterior subtotal vitrectomy with 25 or 27 gauge system, the dislocated lens was elevated using perfluorocarbon liquid. A circular capsular access was performed with the capsular bag supported by retractor hooks. Following hydrodissection, an intracapsular ring was implanted and phacoemulsification was performed. For capsular bag fixation, a device by Serhienko and Kondratenko was used, with the 3 fixation devices sutured 120 degrees apart. A flexible IOL was implanted and the procedure concluded with the removal of viscoelastic and perfluorocarbon liquid. The optimal timing for vitreoretinal reconstructive surgery is 3-14 days after primary microsurgical treatment of penetrating wounds. Modern ophthalmic surgery is focused on minimally invasive techniques with a strong trend toward reducing surgical trauma, including in vitreoretinal procedures, which is performed using a 25-gauge system. Foreign bodies up to 7-8 millimeters were removed through the pars plana when the crystalline lens was clear. If the lens was damaged, or in case of large or irregularly shaped foreign bodies, removal was performed via the anterior approach, a technique for removing a dislocated crystal lens while preserving the capsular bag has proven effective. This method allows lens extraction through the small self-sealing incisions, reducing intra- and postoperative complications. It also enables the implantation of any model of soft IOL, ensuring a stable and well-centered position. For traumatic retinal detachment combined with aniridia and traumatic cataract, a staged surgical approach is preferred. The first stage aims to restore optical media transparency, and the second stage implantation of the iridocapsular diaphragm. Thank you for your attention. It's a great pleasure to present at such Congress, and glory to Ukraine.
Thank you very much, dear Igor. And now, as we have had a little bit technical issues, could we open Professor Serdyuk presentation
Yes.
about...
We have received Serdyuk presentation, and we're just opening it up for you. We also received Dr. Olga's presentation. I think Dr. Tatiana's presentation needs to be sent. Yeah, even that also received. Yes, Dr. Tatiana. Thank you.
The next one is a presentation from Dnipro, Professor Serdyuk Valery, our experience in combat surgery from 2014 to 2024.
Yes. So we're ready with Dr. Serdyuk's presentation. He's displaying that.
If you don't have it from the hall, I can try to share it from my side.
You got it.
Let me see if I can. Oh, okay, they're already doing it. Okay, great.
Everybody, I would like to introduce our experience in combat injury surgery from 2014 to 2023.
It is okay.
Analysis of the literature shows that the proportion of the visual lesions, both isolated and combined, in the overall structure of traumatic injury can be very significant and range from 2 to 15%. The incidence of eye injury during the arm conflicts varies from 0.5 to 13%. Evaluation of warfare tactics has led to the fact that anti-personnel miners and various explosive devices, both improvised and produced by industry, becoming the main causes of eye combat trauma in all military conflicts. Other causes include wounds from firearms and accidents. The increasingly severe multiple and combined injury causes by modern military weapon require new organizational solutions, high medical qualifications, and significant efforts to preserve the life, combat capability, or working capacity of the maximum number of wounded. Now I would like to introduce the principle of medical care for wounded with a visual injury. Level 1, primary basic, the medical care directly on the battlefield, application and the aseptic bandage, mono or binocular, with the help of IPP, intravenous anesthesia, and after evacuation. Level 1, primary medical care, medical point of battalion, regiment, or company, epibulbar anesthesia, I would like to remind you about a very simple, very important procedure like washing the eye surface. It's a wound washing. Installation and penetral administration of antibiotics, antiseptics, removal of superficial foreign body, and tetanus anotoxin. Level 2 is qualified medical care, ophthalmology or military hospital or medical institution of the Ministry of the Health of Ukraine, optimally 4-6 hours after injury. Removal of superficial foreign body, epi and parabulbar antibiotics. Level 3, specialized medical care, rare hospital based on medical institution or Ministry of the Health of Ukraine, according to the protocols of management of patient with visual injury approved by the Ministry of the Health of Ukraine, and auto-reconstructive surgery. And finally, level 4 is a rehabilitation of the wounded. Dnipropetrovsk Regional Clinical Ophthalmological Hospital is the only hospital in the region and one of the few in the Ukraine that provides highly specialized ophthalmologic assistance to servicemen injured in the war zone and temporarily displaced persons from the eastern region of Ukraine and the Crimea. In our clinic, we've done from 2014 to 2021, assistance was provided to 1,155 participants of the anti-terroristic operation. 470 surgical interventions were performed on patients. Of this, 77 operations were performed on the basis of the Dnipropetrovsk Regional Hospital named after Hospital Mechnikova, non-transportable serious patients. 530 examinations of servicemen were carried out in the consultative and diagnostic polyclinic. Now you can see the medical care provided in 2022, our clinic. 3,508 Hello, everybody. I would like to introduce our experience in combat optimally for in the consultative and diagnostic polyclinic.
Thank you so much.
Now you can see the medical care provided in 2022, our clinic. 3,508.
Yes, Dr. Oksana, the presentation was till this time. Yes, so that was the presentation that we had.
Thank you. Thank you. I just only want to mention that this is one of the main hospitals who take care about participants and organize eye care with the most severe eye trauma, combat trauma. So thank you, and sorry also for some issues. The next presentation is from a group of authors, and it's not very polite from our side to keep in mind to introduce ourselves. So we will introduce speaker Tatiana Komarova. She is ophthalmologist that is specializing in retinal pathology, eye trauma, and minimally invasive interventions, and works in the Department of Ophthalmology at Bogomolets National Medical University, and combining clinical practice with academic teaching and research. Please, the stage is yours.
Thank you so much. Yes, and
dear colleagues, thank you so much. And I'm incredibly happy to present our work at OPHTHALMOLOGICA 2025 and sharing our research with experts from around the world. It is an amazing opportunity to discuss innovative ideas and to gain valuable insights. The inspiring atmosphere makes this experience even more unforgettable. I'm happy to share our research through a pre-recorded presentation, if it's possible to share it.
Yes, it's possible to share it. We are playing the presentation from our end. Thank you, Dr.
Thank you so much. Good afternoon, dear colleagues. Let me introduce our work. The war launched by Russia against Ukraine has already caused irreparable harm to thousands of people. We witnessed terrible human suffering, destruction, and loss. Many people were forced to leave their homes, fleeing the war. Those who remain in the war zone live in constant fear for their lives. In the combat zone, the risk of serious injuries, including eye injuries, has significantly increased. Explosions, shell and shrapnel, and other factors of war lead to injuries and deaths every day. Eye injuries can be very serious, leading to partial or complete vision loss. Many people lose not only their eyesight, but also the ability to work and lead a full life. Modern wars and military conflicts are characterized by the use of highly destructive weapons, causing eye injuries, the frequency and severity of which has increased significantly in recent years. According to the literature, traumatic eye injuries account 16% of all combat injuries and are the fourth most common cause. This indicates that the eyes are one of the most vulnerable organs during combat. According to the International Society of Ocular Trauma, there has been an exponential increase in its frequency during military operations in recent decades. This is due to several factors, including using of a more powerful weapon, increasing civilian casualties in wars. In modern wars and military conflicts, compared to the First and Second World Wars, there has been a six-fold increase in damage to the visual apparatus. Despite the fact that the eyes occupy only 0.1% of the total and 0.27% of the anterior body surface, they are disproportionately affected in blast injuries. By the 20th century, the rate of eye damage was 4 times lower than expected, based solely on the body surface area. However, the development of new weapons with greater explosive and fragmentation power has led to a more than 50-fold increase in the proportion of eye injuries compared to the expected percentage in the late 20th and early 21st centuries. This significant growth can be explained by several factors. Increase of the use of explosive weapons, urbanization of war, insufficient eye protection. As a result of these factors, the proportion of war-related eye injuries has increased significantly in recent years, as it is presented on the slide. And it is important to know that the eye injuries during war are often bilateral, when due to the peacetime they are more one-sided. In practice, we use the Birmingham Eye Trauma Terminology System, which was developed in 1996. It is clearly and simply, and it describes all types of injuries and divides them into categories. Later, attempts were made to improve this classification, but none of the proposed variations was as convenient and consistent. Our hospital provides assistance for the injuries to military personnel. This is provided 24/7 for outpatient emergency care and inpatient care as part of evacuation. In the structure of trauma of outpatient clinic, 94% are closed eyeball injuries, of which 63% are superficial foreign bodies of the cornea and conjunctiva. 18% are non-penetrating injuries, such as corneal abrasions, and 13% are contusions of the eyeball. For the open eye injuries, they account for 6% of the total number of injuries. Penetrating eye injuries predominate among them, 4%. Among inpatients clinic, the structure of injuries is somewhat different. Closed eyeball injuries slightly predominate, accounting for 56%. In most cases, this category of patients is diagnosed with eyeball contusion of varying severity. Among open eyeball injuries, we observe penetrating injuries of one or both eyes in 21% and the presence of intraocular foreign bodies in 16%. The increasing frequency and severity of eye injuries during war and military conflicts underscores the need to take measures to prevent them and improve treatment. Rehabilitation is a necessary component together with health promotion, disease prevention, treatment, and palliative care. Its goal is to help people to restore their independence as much as possible in everyday life and to participate fully in study, work, recreation, and fulfill important social roles. Worldwide, approximately 2.4 billion people are living with diseases, which can be improved through rehabilitation. Currently, the need for rehabilitations is slightly unmet. In some low and middle-income countries, over 50% of people do not have access to necessary rehabilitation services. Emergency situations, such as conflicts, natural disasters, and epidemics lead to a sharp increase in the need for rehabilitation. Rehabilitation is a key strategy to achieve Sustainable Development Goal 3, ensuring healthy lives and promoting well-being for all at all ages. Rehabilitation can include a wide range of activities aimed at helping people with various diseases and injuries to restore their functionality and improve their quality of life. It is important to remember that rehabilitation is a process that takes time and effort. However, for many people, it can be a path to a more independent, productive, and fulfilled life. Rehabilitation after eye injuries have certain nuances. On initial stages of evacuation, victims with eye injuries are often given complex operations. The task of doctors at this stage is to implement the most effective intervention, that to preserve one's sight and to create the conditions for further successful rehabilitation. The next thing we want to emphasize is that one of the most pressing problems in war conditions is the shortage of qualified ophthalmologists who can provide the necessary assistance to the victims. It is important to attend the attention of international community to this problem, attract specialists and resources to provide quality ophthalmological care. For example, at the initiative of charitable and public organizations, medical missions of Canadian and American plastic surgeons, ophthalmologists, and otolaryngologists are taking place to perform surgical interventions on military people. All assistance is completely free of charge to our wounded. There is also a process of training for our doctors in the latest surgical techniques. Ocular prostheses are becoming an important component of physical and psychological rehabilitation of people who lost one or both eyes due to the injury. Thanks to modern technologies, prostheses are manufactured with maximum precision, approaching the natural look of the eye. It helps people to get used to their new image, improve self-esteem, and return to a full life. This slide presents medical institutions that manufacture individual ocular prostheses. Some centers in Vinnytsia and Odessa provide free prostheses to wounded soldiers. Another opportunity to get an eye prosthesis for military people is I Give an Eye campaign, where everyone can donate a certain amount for a specific wounded person, and each military person can submit their candidacy. Vision loss due to combat can have destructive influence on the mental state of both the victims themselves and their loved ones. This can lead to post-traumatic stress disorder, depression, social isolation, and rehabilitation problems. Psychological support may include individual and group psychotherapy, family therapy, social support. It is important that psychological help is available for all military people and their families. This can be achieved by training a psychologist or other specialists on the issue of working with people who have lost their vision. Creation of specialized rehabilitation programs. Securing financing to provide psychological assistance. And reducing stigma around mental problems so that people are not afraid to ask for help. The war in Ukraine has caused unprecedented challenges for ophthalmology. Number of eye injuries related to hostilities has increased significantly, which led to extreme load on healthcare system. Many medical workers were forced to leave their jobs, and hospitals in war zone suffered significant damages. This led to shortage of qualified ophthalmological care and limited access to necessary medicine and equipment. In these difficult circumstances, we must join forces to provide adequate medical care and rehabilitation to the victims. This includes developing better eye protection equipment and raising awareness of the risk of eye injuries among military personnel and civilians, providing emergency medical care for people with eye injuries, carrying out complex operations to restore vision, providing rehabilitation services that will help people learn to live with vision loss again, and supporting psychological health. It is important to continue research and development of new methods of treatment and rehabilitation for traumatic eye injuries. Together, we can help people affected by war restore their vision and return to a full life. Thank you for your attention.
Thank you very much, Dr. Tatiana. And it's my great pleasure to invite the next speaker. The next speaker is Olga Denisyuk. She is Associate Professor in the Department of Surgical Disease with the course of Anesthesiology and Intensive Care of the European Medical School of the International European University, Kyiv, Ukraine. Also, she is a teacher of the European School for Advanced Studies in Ophthalmology in Switzerland, and she will speak about the multidisciplinary approach to reconstruction of the periorbital area after mine blast injury. The stage is
Hello,
yours.
everyone. Thank you for inviting me. It's a great honor and a great pleasure to share our experience and our multidisciplinary approach to our soldiers' rehabilitation.
Thank you very much. This has been a very interesting session, very enlightening and eye-opening. But I just have a question, Professor Oksana, if I can take the question before we go to the next speaker, is how has the life been, how is the life right now of an ophthalmologist in Ukraine and also of a civilian in Ukraine? How do you go about your daily activities?
Thank you so much for your question, and first of all, again, for your great support. Now, of course, the situation is different from 2022, and we, of course, work in very difficult circumstances, but nevertheless, all our governmental and private clinics, all of them, they're working and even increasing their eye care for our people. Only we have some difficulties, of course, with rehabilitation, and we have some difficulties with protection if we're speaking about war trauma. And I think my colleagues could add shortly, for instance, Dr. Olga Denisyuk, as she is also involved, and Dr. Igor Vasiltsev, as he is also involved to eye care from different parts. Olga from governmental and Igor from private clinic. Olga, shortly, please. Would you add something?
Yes, it's been a very big challenge because the vast trauma that we get and the lives that we had, the time changed from before and after the war and after the invasion of Russia. Of course, we had to adjust our schedules, and now it's, as Oksana said, it's very different because we now adapted to lights and connection problems. But before that, we had to invent new methods and new ways how to live and how to adapt to new situations, and working without any lights or heating in wintertime, and working in constant bombing. But we're here and we're staying and we're helping our fellow Ukrainians to survive and eventually come to our victory.
And
also, sorry, I would like to add that many our hospitals and clinics are destroyed, unfortunately. So that's
Yes.
why it's also another challenge that we are faced to.
And I'm sure it's not even unimaginable for people outside Ukraine to understand the not just the trauma, as you said, the physical trauma, but the mental trauma and psychological trauma goes way beyond not even a civil, I mean, the military personnel, the healthcare worker, and ophthalmologist faces. And I mean, every person in your country must be facing that, and I hope that it gets better soon. And the whole world is there, united in this support. I'm sure it will happen very soon. And just one more question: what is the percentage of civilian and eye personnel who actually get injured in this trauma? Are the eye doctors also affected in injuries? Do they bombarding? Do they inform that this area is going to be a high-risk area that you evacuate? How do you live in that fear and that emotion? How do you manage that?
Sure, many doctors also are injured during this war, and not only because on the front line, but also in far distance, as I mentioned, and Olga mentioned that we are under attack every night and every day with missiles, drones, that's many civilians and also included doctors are injured. As example, last August, the biggest pediatric hospital was destroyed. Some buildings after attack directly on this hospital. And of course, nevertheless, we continue to work and support each other.
Thank you. Thank you.
And let me use this opportunity also to express our deep gratitude to all our colleagues from all over the world, and also personally to you and as organizers, that you let us to share our knowledge and our experience today. We are grateful for your great support as emotional, also with some medicine and supplies at the beginning of this big war, when it was very, very difficult situation in Ukraine, and you continue to stay with Ukraine. Thank you very much for this.
Thank you.
So let's, and Olga, stage is yours.
Thank you.
It will take 2 minutes for Dr. Olga's presentation to do that download. In the meanwhile, if we can present Dr. Anke's presentation, would that be all right?
Sure.
Thank you. Thank you so much.
So then it's my turn to introduce Anke to the podium. From my end also, thanks a million to all the speakers to share this deep insight into your daily life. It's really touching, depressing.
Topic.
No, just a second, please. I'm really impressed. I'm deeply impressed by what you're doing all the time, and I have no words to express my gratitude to you, what you're doing and sharing with us. So Anke will be our next speaker. Dr. Anke Messerschmidt-Roth. She will report about assessing visual acuity without any optical devices. Anke is also very, very experienced lady. From 2009 on, Anke is the head of the study research department of the eye clinic at Philipps University in Marburg in Germany. She supervises also investigator-initiated trials on refractive surgery and manages the refractive consultant services. From 2019 on, she's also active as an independent coach and consultant for the refractive surgery industry. She is advising companies and trains the professionals, including physicians, optometrists, to enhance their experience. And good to know, she holds a PhD in optical engineering. So welcome, Anke, to the stage. The stage is yours, please.
Thank you very much for the invitation. And yeah, I'm really pleased to give a talk about the visual acuity and how to measure it without anything. Because initially I was an optician, and I studied engineering for opticians. So the basic, what I learned was optic. And so, yeah, welcome to my talk, and please, can you start with the video? Does it work? Why did I choose this topic? Assessing visual acuity without any optical devices. A good question, isn't it? In 2003, I read a book about the visual care in concentration camps during the Second World War. And once I never forgot, there was written how prisoners produced glasses from the bottom of bottles to correct the visual acuity or to improve the visual acuity. And that brings me to the question which never leave my mind. Is it possible to measure the visual acuity and to determine the dioptrin of glasses which are needed without any devices? So that brings me to the question, what influences our visual acuity? And if you look at the German industrial norm, one point is very critical, that is a light condition. So if you test the visual acuity in a dark room, that will give you different results than you would do it in bright sunlight. So light conditions greatly affect your perception and so also the visual acuity. Before we determine how well someone can see, we must first understand what seeing actually means. Seeing is the ability to perceive two points as separate from each other at a certain distance. This ability is referred as visual acuity. Visual acuity depends on a distance. A person with a visual acuity of 1.0 or 100% can distinguish 2 points of 0.29 millimeter apart at a distance of 1 meter. That means at 3 meters, the points must be 0.78 millimeter apart to be seen separately. And at 6 meter, that is a critical point at 6 meter, because this is a definition of an ametropic measurement. So at 6 meter, we have 1.75 millimeter between these 2 points. At this slide, I calculate the distance. It's only an example. So if we have a 6 meter distance and a person can see these dots in a distance of 1.75 millimeters, we have 1.0 visual acuity or 100%. If the person can see these 2 dots in 3 meter, the visual acuity is only 0.5 or 50% of a normal vision. It's a normal mathematic calculation. Once visual acuity is determined, the next question arises. What lens strength is needed to correct it? This is where the term diopter comes in. Diopter are simply a physical measurement unit. They are calculated as a reciprocal of a focal length in meters. It's shown there. Normal opticians use step tables that provides guidance on what lens power is needed for different levels of visual acuity. One example is shown there. So if you have a visual acuity of 0.5, you need a sphere of 0.5 or a cylinder of 2.0. That's easy. By identifying the distance at which 2 points can still be seen separately, we can calculate the visual acuity and from there determine the necessary lens power. It's shown in this table. So if we have a distance of 3 meters where 1.75 millimeter can be seen, the visual acuity is 0.5. There is a simple example. Let's say someone can only recognize these 2 points in a distance of 1.75 millimeters, which is for a visual acuity of 100%, apart from 3 meters away. This corresponds to a visual acuity of 50% of normal vision. The correction should be nearly minus 0.5 dioptrin. With this correction, the person would be able to see the same points clearly from 6 meters away. That brings us back to the initial question. What do we really need to determine visual acuity? No high-tech equipment. No complicated devices. Just a few simple items. You will need a pen, a white sheet of paper, and a step length of about 1 meter. With these basic tools, you can determine visual acuity and even estimate the required dioptrin to help people with a bad visual acuity. Thank you very much.
Thank you so much, Anke, for this interesting presentation. One question to Oksana as well. Do we have still one lecture left, or are we done with all? Because we mixed it up a little bit.
One lecture left, Dr. Olga's lecture. We're just playing that just now.
As we are time over, so don't lose time, and Olga is your stage.
Thank you.
Dr. Olga, we're just playing your presentation. Yeah, we have it here. Just 1 second.
So if you could click it through, because it's pre-recorded and each slide has a pre-recorded video to it.
Perfect. Can you see the presentation there?
Yes. Hello, dear colleagues. It is a great honor to present my speech.
Yes.
My name is Olga Denisuk, and this is my talk about multidisciplinary approach to treatment of orbital trauma. During the 3 years of war, we have assembled a multidisciplinary team that now works as a full-fledged reconstructive machine, conducting training, learning, and exchanging experience with the whole world. We are now one of the best surgeons in trauma department. This is a quote from my American friend and a great teacher, Stuart Seif. This is him on the photo. Let's talk about combal facial injuries. They are quite common, unfortunately, and as is part of the bodies exposed most in combat conditions, according to research among all wounded combatants, in Ukraine, 18 to 25% have facial injuries. Up to 2/3 of these injuries require specialized, highly qualified surgical care. In this slide, you can see one of our soldiers who's been fighting a war against Russia. This is a mine blast injury. You can see his primary reconstruction. He had bone reconstruction with plates. He had skull reconstruction. You still see that he has a lot of scarring on his face. Going through surgery after surgery, we have managed to fix his lids for him to wear a prosthetic eye, which makes his life a little bit easier. Still have a long way to go to work on all of these scars on the face, because when our patients, civilians as well as our soldiers, having injuries on their face, you can hide them, you cannot hide them. So by making them look as normal as we could, we are restoring a little bit of humanity in their lives. Today, we use modern technologies, 3D printing of patient-specific implants, the latest methods of surgery and eye prosthetics to create the best condition for the rehabilitation of our military and civilians who have been suffered from Russia's barbaric actions on my country. Working in a multidisciplinary team, making patient-specific implants, all comes to having a good prosthetic eye fitted in, which makes their life a little bit easier, and social adaptivity in normal life much easier, and the transition much easier, because a lot of our patients suffer that kids are afraid of them and people on the streets are looking and they don't feel comfortable. We currently work an Ukrainian and international multidisciplinary team. We have maxillofacial surgeons, oculoplastic surgeons, neurosurgeons, plastic surgeons, ENTs, and dermatologists all come together to achieve the best aesthetic result for our patient. Because only working in a team, we can offer our patients the best care that is possible. 3D printing, after reviving and evaluating the CT images of the injury, we transfer them to special computers and engage with bioengineering and subsequent 3D printing of patients' individual implants for the reconstruction of the orbit and facial skull. With the help of our colleagues from United States, we have contacted Dallas-based company called MedCAD. This is not a commercial. They've been helping us. We've been working on this project. We already have 3 patients. One of them had a reconstructive of his mandibula with a vascular flap with fibula. And you can see that his 3D scan is here. This is an American soldier fighting the Ukrainian war, so helping him was one of our victories in the war. Of course, we have a Ukrainian company that has done a lot of 3D printing, and we have a lot of experience, not only in oculoplastics, but in craniofacial surgery, maxillofacial surgery. And we have now over more than 1,000 successful surgeries performed, and unfortunately many more. You can see here is an example of one of our patients. We've been reconstructing his frontal bone, his orbital floor. And you can see this is one of the surgery. And this is him before and after surgery. You can see that enophthalmos is gone. His eyes have a good line. He has no more double vision, and now he is very happy with the outcome of surgeons. Another example of our patients, and this is one of the big multidisciplinary team, we work step by step in preparing the orbital cavity for rational ocular prosthetics. We use 3D printing to rebuild the skull, and then brick by brick we rebuild the orbit using orbital implants, and then which leads to good prosthetic eyes. If everything is done correctly, we will have a good result eventually. So we have to fight for our patients, and you can see here our primary reconstruction of the patient was done the best as it was possibly could in this along the front lines in the hospital. Then this has been taken to a 3D patient-specific implants. You can see his zygoma, maxilla has been reformed, his orbital floor has been reformed with patient-specific implants, and you can see the post-op result of this patient, which could then lead to good ocular prosthetics.
Preparation of the orbit is much important, as well as preparation of the bony part of the orbit. With the evisceration and nucleation, we try to put orbital implants if it's possible. If it's not possible, done primarily, we do a secondary orbital revision, take out the debris that has not been taken out there before, or sometimes find some new debris that wasn't expected to be there. Of course, we put an orbital implant and try to form a mobile stump with the residual muscles that are to be found, if it is possible. And we do a good base, and then we send our patients to ocularists and anaplastologists that work with us, our team. This is an example of one of our patients. This is a multidisciplinary team approach. This patient is our soldier. He has been flying drones and got his trauma during battle. Unfortunately, he lost his eye, so we did a reconstruction. We put in an orbital implant, and you can see that is him recovering on the 5th day after surgery and 2 weeks after surgery. Then we send him to our ocularist. Our ocularist is actually a dentist who's been working in our team and has been very excited about ocular prosthetics because the similarity.
Thank you very much, Dr. Olga. Unfortunately, because we are running a little late and other faculties might leave early, we're just cutting it short a bit. I hope you don't mind. And thank you very much for this wonderful session.
Thank you.
Roxana and everybody there. Thank you very much. And now we move on to our next session. Thank you so much.
May I please interrupt you and say, from my end, a big thank you to all the speakers we had and for sharing their deep insight in their extreme work they are doing. Thank you so much. It's such an important topic these days. Thank you, thank you, thank you. Bye-bye from my end, and дуже дякую і до побачення. До зустрічі в Києві. Bye-bye, dears.
Thank you very
Bye.
much.
Thank you very much. I'd like to start